Thank you, Dr. Thompson. It's really an honor for me to be here, especially given the fact that over the weekend as I was preparing, I was researching the namesake's history and his impact on critical care medicine and what he's brought to the field. And it seemed to be very fitting that a lecture on value-based care and how it really helps to define the patient experience fit with his legacy and what he accomplished at Pitt and also in the history of critical care medicine. I should warn you that, as you heard, I am a colorectal surgeon, which means I have the attention span of a 2-year-old, so I tend to move around. I'll try and stay in one place so the camera guys don't get angry with me. So as you heard, I was the Chief Experience Officer at Cleveland Clinic. This is what my first day looked like. I apologize, I have to provide a little humor from the colorectal side. It's what we do. We have the best jokes next to the urologists. This is my only narcissistic slide, but I want to share with you what was an epiphany for me on patient experience that I think will resonate with some in the audience. It was actually December 22nd, 2004. I had just got back home from shopping, and I was exhausted. I went to bed. My phone starts ringing, and I was laying in bed debating whether I was going to answer it because I was really tired, having just come off of call. And I picked up the phone, and it was a colleague of mine who was calling to tell me that a patient that I had helped take care of had arrested and died in the hospital. And, you know, we have lots of coverage, lots of backup, so I was debating my next steps, and I dragged my butt out of bed, drove to the hospital in what was the first and worst snowstorm of the season, and I got up to the floor, and we all know the scene of an arrest in a hospital floor. The crash cart was open. There was garbage strewn all over the place. The nurses, who are the Marines, who typically are the first ones to storm the beaches in any emergency, were exhausted. The family was up there talking to somebody from operations, where they were trying to figure out next steps and the arrangements for the body, when 6 hours earlier the family had been told that everything was fine. It's a very surreal environment, and if you've experienced it, and I know speaking to an audience like this, I'm sure there's nobody here that has not, you're often captivated by the scene of what's going on. But what was particularly surreal for me was that the person in the bed that had died was my father. And I'd never been on the other side of healthcare before, and this was a long time ago. This was in my organization before all the changes had taken place. But when you've never been on the other side, when you've never been sick, when you've never had a family member who has been critically ill, you know, you really don't capture what it's really like. You don't have that empathy. And he came into the hospital for an ambulatory procedure, experienced a serious safety event, ended up staying 7 days, and died of a complication. And we didn't use the words patient experience back then. But if you think about all of the events that led up to my experience and my father's experience, what you find is all of the things that we are finally starting to care about today, all of these metrics that really matter, he would have failed our organization on. And we shouldn't all have to be on the other side of care like that to have the epiphany of what it really means for patients and why it's important. Now, as you know, I'm a surgeon, so I have to use cartoons. It makes my storytelling a little bit easier. When I first became the Chief Experience Officer, I had no idea what that meant. In fact, my conversation with my former boss, Dr. Toby Cosgrove, when he asked me why this was important, I basically told him that I thought no one else should die in our hospital, thinking it's the worst place in the world, like my father did. So I had a patient keep a journal, and this is a woman that stayed 5 days in the hospital. She was a 43-year-old female who was there for recurrent rectal cancer, and she captured everything that happened to her. But one of the unintended consequences of the little experiment was that she got the name of everybody that took care of her. And at the end of 5 days, there were 8 doctors. There were 60 nurses and so many other people that when I went in to discharge her on the last day, she said, "Dr. Merlino, I forgot to have 2 people sign the journal." Now, what it said to me, which it should say to all of us, which is just so intuitively obvious that we don't think about it, is that everybody counts in healthcare. And if you think about the least most important thing that we do, which is deliver on this patient experience, the service piece. And I know it sounds a little strange because I'm here talking about patient experience, but it is the least most important thing that we do. Everybody counts. And we all have our stories about how anybody in the hospital has ruined the experience for our patients. But if you ramp up to the second and most important things that we do, which is to deliver high-quality care and ensure safe care, everybody counts for that as well. And in today's environment of complicated medicine, and again, it's an understatement to say that in an audience like this, we have to rely on how we bring people together around this common goal of taking care of people and getting them to think about that every single day and how they work together to drive towards high performance to be successful. And if you look at the data, one of the most interesting evolutions for me going from the clinical side to the business side working with Press Ganey is we have a lot of data. And if you look at the data on engagement of hospital employees as it relates to the patient experience, what you see basically is that when engagement is higher, patient experience is better. And you also see it for physicians. When physicians are coming into a hospital more engaged around the patient experience is better. I hate talking about money, but hospital administrators often want to talk about money. But it's also true that when your people are more engaged and they're more aligned around the person that they're helping to take care of, you do better in value-based purchasing. And by the way, it's also true when physicians are more engaged. Now, it's interesting, when you start to look at patient experience ratings and other clinical metrics like readmission rate, what you see is that organizations that perform better for patient experience have lower readmission rates. And for those of you that follow this, you know that 4%, 4 out of 100 wrongful readmissions or miscalculated readmissions can result in a lot of money lost to an organization. So it's not insignificant. You see it for length of stay. Better patient experience, lower length of stay. You see correlation to a bunch of safety indicators. Higher patient experience, organizations that do better with the patient experience perform better on PSIs. Now, I'm a surgeon, I'm a clinician, and many of you are sitting there saying you can't prove cause and effect, and I will never stand up here and say that. But what you can clearly see are organizations that perform better in patient experience, perform better in safety. There's increasing evidence, more and more published each year, that improved patient experience leads to better clinical outcomes. Probably most meaningful for me was a study that was recently published last year in JAMA of Surgery that looked at 180 hospitals' performance, 103,000 patients, where they looked at things like death, failure to rescue, and complication rate. And in the organizations that had higher patient experience performance, they had lower mortality, higher rescue, and less complications. And they used the NISQIP database to demonstrate the different outcomes. It's the first time that patient experience publicly reported data through Medicare had been linked to harder core outcomes using something like NISQIP. So the evidence is increasing. The evidence is getting better. And what it's starting to demonstrate is that when we think about creating organizations where we action culture, where we get people to come into a hospital or a clinical environment thinking about why they're there all the time, thinking about how they work better together, it leads to that. But it also leads to that. And if you think about value-based care and what it's doing, and we can argue all day about the merits of the ACA and how important that is or not, and the impact it's having on healthcare. But we have to step back and realize that the ACA is not one homogeny of different things. It's a lot of separate different things. And one of the things that it's doing is it's bringing attention to metrics that matter. And it's putting a focus on this idea that we have to be concerned about how we develop our cultures to be successful at delivering on those metrics. Because if we accept that we align our people to be more engaged, if we get our people to work better together, if we develop healthier cultures, we'll have better experiences for patients. We will drive towards better clinical performance, and ultimately, it'll lead to that, which in healthcare we call that. And that's the connection. I think there are 6 elements that we have to think about collectively as we understand how to move our organizations from great performance to outstanding and consistent, highly reliable performance, which is where we need to be to accommodate and compete in the environments that we're facing. We have to commit to this goal of zero harm. We have to ensure that we have patients at the center of planning, delivery, and assessment of care. We have to recognize that things like safety and quality and the service experience are not separate. They're not silos. They are, in fact, connected together. We have to drive change using the data we have and transparency as a tool to help us. We have to focus on culture and leadership, and we have to be better at holding people accountable, and we have to improve our execution. This group knows the issues we have in safety. We've made tremendous progress since the Institute of Medicine report came out in 1999, but we haven't made enough progress. We still have 440,000 people in this country dying from preventable hospital errors. If you count it as a disease, it's the 3rd leading cause of death in the United States. 1 in 25 hospitalized patients have a preventable hospital infection. Senior citizens have a 25% chance of an injury, and it significantly increases costs. My mother is 83. She thinks she has every medical problem in the book, but she has basically no medical problems. But every time she has to go to the doctor, or every time she has a procedure, I worry, because the statistics are striking. This is a chart that looks at number of encounters that cause a fatality in different activities across the x-axis. Along the y-axis is the total lives lost per year, and this is a slide that comes out of a company that we acquired called HPI. Mountaineering and bungee jumping. You shouldn't jump off of mountains using a bungee cord. It's pretty dangerous. Look at where airlines are in European railroads and nuclear power. Very safe, very few lives lost. Driving, not so safe. Look at where healthcare is. Now, as a surgeon, for a long time, I hated the connections between the airline industry and medicine. However, we have to admire the airline industry. I mean, they have achieved beyond Six Sigma elements of safety. And I have to find some wood to knock on because I'm flying this afternoon. But the point is, it's not about becoming the airline industry. It is about functioning more like the airline industry, where all of you know in the particular specialties that you're in, it's about creating better standardization of what we do. We have a long way to go to create better standardization, and we have to commit to this idea that we are going to stamp out harm to patients. And nobody comes to healthcare thinking, how am I going to harm a patient today? But we have to keep it top of mind. We have to remind people about it. We have to make it visible. We have to talk about it. We have to record it. And we have to put a face on it. We have to make it very real. My father was a real person. He's not a statistic. And when you look at organizations that have adopted this framework, where they're transparent about their outcomes, where they put faces on their charts instead of just statistics, it raises awareness for this idea of harm. Putting patients at the center of our planning, delivery, and assessment should be intuitive. We're in healthcare. Of course, patients are at the center. But as I travel around the country working with hospitals of all different sizes from all different systems, in reality, you don't see this. But if you ask people and you pull them aside, do you put patients first? Of course we put patients first. Where is it in your strategic objectives? If you go to the front lines and ask people, what's the attitude on patients around here? Few people can articulate this concept of keeping patients at the center. It must be front and center. for everybody who is a leader in healthcare, and that's all of you. It has to be a strategic priority for an organization because we don't pay attention to it unless it is. And we need our people, our caregivers, our coworkers, every day coming to work thinking about how they keep patients in the center of what they do. Otherwise, we make mistakes. And in our industry, like others that require higher liability, mistakes cost lives. We have to recognize, define, and understand that these things are connected together. Safety, quality, and service experience are not separate. It's not about making people happy. And the unfortunate thing about patient experience in the United States today is that the movement, the effort, the concept has been branded about making people happy, especially with physicians or other clinicians. Oh, you want me to smile. You care less now about me delivering high-quality medicine. You'd rather I be nice to patients. Is that what you're saying? Now, granted, there are some physicians who I have said, yes, if you smiled, it might help a little. But it is not about satisfaction. It is about safety, quality, patient satisfaction, or, as I like to say, having patients walk away and their families leave you feeling like you actually cared for them, that you were compassionate and empathetic. And everything else we do, that's the patient promise. So I'm sure everybody knows what age caps is. Raise your hand if you don't. Good. There are 9 questions on the age cap survey about how we communicate with patients. 3 for nurses, 3 for doctors, and 3 for new medication. Now, clearly, if this were about making people happy, we wouldn't need to ask 9 questions. But when nurses improve the frequency of contact at the bedside and improve the way they communicate with patients, falls go down, pressure ulcers go down, medication errors go down. And those are safety issues. And you don't have to believe me, it's been written in the nursing literature for the last 10 years. When physicians communicate more effectively with patients, compliance with treatment goes up. When physicians communicate more effectively with nurses, coordination of care improves. Those are safety issues. There is no doubt that when we communicate more effectively with patients, they're actually happier too. But the point is that when we focus our strategies and tactics on things that impact all 3, we deliver better value. This is about how we deliver care. It's not about how we deliver satisfaction. And if you had the CMO of Medicare up on stage with me, he would tell you the same thing. We are measuring delivery of care which has never been measured before. That's what the CAPS program is about. And the reason it's important and the reason it's getting so much focus is because we know that safety problems come from poor delivery of care. We know that quality suffers when we don't deliver care better. It's about the patient promise of safety, quality, and service together. This is about what we do and how we deliver it. It's not about happiness. Data is critical. And in an audience like this, I should have eliminated this slide. But I'd like to talk a little bit about patient experience, patient satisfaction data. Because I talk to a lot of physicians. And often physicians will say, well, Jim, the age cap survey, it's never been validated by a randomized controlled trial. And it's not really been tested very well. And by the way, a sample size of 3 doesn't really help me. And I say, well, most of what you do in medicine has never been validated by a randomized controlled trial. By the way, that's true. When I was at the peak of my colorectal practice and I got this new position at Cleveland Clinic, I listed out the 30 top procedures that I do. Only about 80% of them, actually only about 20% of them, had good data to support what I was doing. It's kind of striking, actually. Probably a little bit better for your specialty, but a lot of what we do in medicine has not been validated by really good studies. And if you look at the development of the CAPS program, it's actually pretty good. In concert with ARC and RAND, and you don't have to believe me, You can go on AHRQ's website and read about it. But the data is the data, and we have to consider how it's used. And we can debate all day whether asking patients to evaluate us is the right way to do it. But that ship has kind of sailed. And the best way to change that is to write your congressman, because that's the mode that's been chosen. But let's get past the arguments that it's bad data. And let's accept that it's a piece of information, like a lot of other pieces of information that we use to try and improve what we do. This is the voice of the patient. And we should accept it for what it is. It's providing us with important information. And the sample size, yes. So I think you would need probably 1,000 surveys per snapshot to have a statistically validated sample. But if you're a physician, and I talk a lot about physicians because I am one, and I show you 1 month of data and you're in the 10th percentile for how patients rate your communication, I might sit you down and say, you know, those patients probably didn't like you and they were just being mean to you, so they rated you really low. In the second month, when you come to my office and you still have a sample size of 3 and you're still in the 10th percentile, I might say, those patients must be really picking on you by rating you in the 10th percentile. But jump ahead 8 months and 8 snapshots, and you're still in the 10th percentile, I think it may not be the patient. And in fact, for every physician that's in the 10th percentile for an N of 3, there are physicians in the 80th and 90th percentile with an N of 3 as well. So we have to consider it, what it means and what it's telling us. And here's an example. So this is a listing of 7 different comments by 7 different patients for one surgeon over a 90-day period. And these were comments that came out of the back of an age cap survey, because some organizations will allow patients to write in comments and some won't. So clearly there's 7 anecdotes. But I think the message here is that there's clearly also a patient satisfaction problem. Does anybody want to argue that that's not a quality problem? And it's also not a safety problem. It is, right? So again, we have to keep the data in perspective. It is the voice of the patient. And while I would never sit a physician down with 1 bad anecdote, I would probably sit a physician down with 7. We have to understand the data, and we have to use it as another tool to help us have a line of sight into our activities. Transforming culture and leadership. We should accept that every healthcare provider should be compassionate, humanistic, deliver empathetic care. But it's something that we often don't think about. And when you consider the stresses of healthcare workers today and the environments they work in and the levels of burnout with nurses and the levels of burnout with physicians and the amount of compassion fatigue that we're seeing, we have to think about how we reignite the passion that brought us all into healthcare to begin with. We can't just assume that every day our people are walking through the door and they're going to be compassionate, they're going to be humanistic, and they're going to be empathetic. And again, nobody comes into a healthcare environment wanting to deliver the opposite of those things. But we lose the passion. And it's our responsibility as leaders, it's our responsibility in organizations to reignite it and ensure that we're delivering programs for our people that help them get the compassion back, understand the humanism, and bring the empathy. It's not always intuitive, and we lose it. We need to teach people skills like high reliability. It's interesting, if you talk to leaders in the military, or you talk to leaders in nuclear power, which, by the way, have very, very, very small error and safety events, they don't talk about high reliability. They just talk about it's the way we do it. We are focused on safety. But they are highly reliable industries because when they make mistakes, the consequences are dramatic. When nuclear power makes a mistake, the consequences on all of us could be dramatic. There's not been a mistake in the United States since 3 Mile Island. And that is the time when the industry shifted from profit and revenue to safety. Not one error since 3 Mile Island. We need to teach those skills to healthcare workers because they're not only skills that bring safety, that improve quality and improve the experience, but they improve everything we deliver in healthcare. And not a lot of organizations understand it. We have to teach emotional intelligence. I remember one time when I was an executive at the Cleveland Clinic, I was asked to interview a prospective partner chair or a prospective chair for a department. And I came down to a friend of mine's office whose name was Mark Harrison. He was the chief medical operations officer at the time. And we're sitting in Mark's office interviewing this guy. And we were with him for 90 minutes. And we didn't say a word. He just talked and talked and talked. And finally, Mark's assistant knocks on the door and says the interview is over. And we said our goodbye and he left. And Mark looks at me and goes, "That's 90 minutes of my life I will never get back." But the point is, and he didn't get hired, by the way. But the point is, this is an under-recognized competency in healthcare that most of us have never heard of. Many don't understand, and it's critically important. And it gets to fundamentally understanding how we as leaders interact with people. Do we talk more than we listen, or listen more than we talk? How do we interact in our environments? How do we manage people? How do we hold people accountable? How do we have critical conversations? How do we work in teams? How do we motivate people? How do we be more empathetic towards not only patients, but our coworkers? It's a critical element of culture, and we all need to be thinking about it. Now, saying that we preach teamwork more than we teach teamwork to a bunch of ICU professionals is probably not the best line, because I think we should be holding up critical care medicine specialists as a model of teamwork. But I bet that I could randomly select 10 people in this audience, and you could clearly articulate right this minute an example of a situation in your environment, in your hospital, where teamwork doesn't exist. Not in your department, but where you've probably experienced it with another department. We preach teamwork in healthcare, we don't teach it. We have to do a better job of driving this competency. Healthcare today is inherently complicated. We used to joke that every bed in our main campus was an ICU bed because the complexity of the patients today is just so much different. I mean, I remember when I was an intern and a resident, it was nothing like it is today. People are sick. They're living longer. They have more medical problems. Healthcare is not an individual sport. And many of our colleagues in medicine, in nursing, in allied health professions, in leadership positions that are not in clinical delivery don't understand this. We have to do a better job of teaching teamwork. And where does it start? It starts here, interprofessional education. It's interesting that I went to a medical school. It was physically attached to a nursing school. And in 4 years, I did not sit in any class with a nursing student. Not once. And they didn't sit with us. Then, even in my clinical time, 3rd and 4th year of medical school, I'm up on the floors, interacting with a bunch of people. Nursing students are up on the floors, interacting with a bunch of people. We're really not working together. We're doing our thing. They're doing their thing. And then what happens? We go into residency and internship. They go into their young careers. And the same thing happens. We're siloed. And what's happening today in healthcare? Hospital systems are spending millions of dollars, many of our clients, to retool their cultures to get people to work together. Where we should be investing some of our money is in the beginning, around how we bring together different professions in health so that they start to socialize and work better together. And it's not just doctors and nurses, it's pharmacy students, it's social worker students, it's dentists, it's health professions at every level. How do we socialize them in the early days when they're just starting to learn? How do we keep them socialized as they progress through their education and their training? And how do we further develop those skills as they're young professionals? That will take a generation to change. But it is a critical element of thinking, where do we start to invest to retool our cultures? And many of you have direct access to this. Many of you can influence this today. Interprofessional education, how do we do a better job of bringing people together around the critical competencies that are necessary to deliver high performance and high reliability in healthcare? Now, since I'm up on stage, I always get a little soapbox slide, and it's bullying. Now, I'm not going to ask people to raise their hand if they've ever experienced it or have seen it in the last 30 days. The United States, and I think across the world, we've made tremendous progress on this. Great work decreasing bullying in healthcare. But we have a lot of work to do. And if you think again about what our collective goal is to build that culture, to be successful, not only to deliver on the patient experience around safety, quality, and service, but everything else we do in healthcare. And you think about the elements that undermine that culture. Whether it's overt or covert, this is one of them. And we all have a responsibility to call it out. And if you think about the namesake of the lecture that I'm giving and the work that he did to bring together teams, it's part of that legacy of what this society represents and the way you've transformed the delivery of critical care medicine. I can't leave the culture bullet without talking a little bit about organizational immunity. I work a lot with hospital CEOs, and they ask me often, what is the barrier to change, or what are the barriers to change? And inevitably, at the top of the list is your culture. And this is a title of an article in Harvard Business Review about 8 years ago called Organizational Immunity. And it was a great article for healthcare because what it does is it uses the immune system as an analogy for how difficult it is for organizations to change, because the immune system rises up to attack something that's different. Just as healthcare organizations rise up to attack change, it's the same concept. The only way we can be successful in starting to tackle our cultural elements is to recognize that we will get a lot of resistance. And you have to put paint on the barriers so that people see them and understand them. And we all know what they are. Oh, I did that here 10 years ago. It'll never work. Or my favorite is, yeah, we tried that at the last organization I was at. That's not going to work here. It's little things like that and others that create this inability for us to move forward. And we have to be progressive about challenging things that a lot of people say won't work, when in fact, maybe they didn't do it right 10 years ago. Maybe they didn't do it right in their previous organization. Now, physicians specifically, I think, deserve mentioning separately. I talked to a lot of doctors about how to better accommodate the changes in the environment today. And invariably, when you're speaking to a group of just physicians, and I know this group is not that, but what you hear is this: well, you know, I have 10 patients today. I only have 2 hours to see them. I'm behind on my medical record because we just implemented this new EMR platform, which means that I have to close my charts at night, and I can't see my wife. She's mad at me and probably going to leave me because I couldn't go to my kid's baseball game and I couldn't call my patients back because all the messages backed up and I couldn't round ... Anybody ever heard something like that before? It's the homogeny of the problem. And what I tell physicians is that the problems that we face today, and I tell leaders of healthcare organizations that the problems we face are not one homogeny. It's like anything else we do in medicine, we have to break it down, and it becomes a matrix. There are things that we as administrators, and I put myself in that category as a physician who led, have to deal with. We have to validate that for physicians, it's different today, and it's hard. We talk about patient suffering. We talk about caregiver suffering. Physicians are suffering today as well. And it's not insignificant with record levels of burnout, compassion, fatigue, and stress. We have to do a better job communicating, and we have to be inclusive. As leaders, when we speak to medical groups, we tend to be one way and very prescriptive in how we communicate. And we make excuses for how we're inclusive, but we're often really not inclusive. I was at a hospital a few months ago where the leader of the surgery area said to me, "I can never get the doctors to buy into our changes." I said, "Well, tell me what happens." "Well, we have this committee. It includes doctors. And we do all this work about how we're going to make a decision for something. We bring the doctors in, get the committee together, and vote on it, and they never support us." I said, "We didn't really include them. And by the way, you're a private practice hospital where you're holding meetings at 10 o'clock and the surgeons are supposed to be operating." So we have to make efforts to include people more. We have to make the communication two-way because we have a tendency to communicate one way. We have to make it clear that we are partners, administrators, and physicians. And we have to own the operational issues. The biggest complaint from physicians in the United States today is that there are operational issues that interrupt their practice flow, which creates significant stress on their environment. And physicians don't own the operational issues. We do. And we have to fix those. When I talk to physicians, I tell them, and it's different today. And the sooner that we recognize it, and the little more that we do to help understand how different it really is, the easier it's going to be for us to get past the things that we don't like to work on the solutions. Let's stop arguing about value-based care. Let's stop arguing about meaningful use. These are things out of our control. Let's help understand how it's going to impact both of us, because it's not just you, it's also impacting me. And let's get back to this idea of partnerships. But I need you to own safety and quality and behavior. For too long, we've allowed that to slip. And only the physicians, through the medical executive committees, can own fixing safety and quality as it relates to healthcare delivery at a health system, and behavior as well. And you need to do a better job holding your peers accountable and monitoring them for performance. And we need to have a little humility, because this is hard for all of us. But that homogeny that I described is not one problem. Too many patients in 2 hours is a template management issue. Physicians closing their charts at night means that we've probably done a good job teaching the physician how to use the EMR, but we've probably done a terrible job teaching them how to integrate it into their practice. Not being able to call your patients back may mean they don't have enough support. So we have to break the issues down and solve them one by one, because it's not one problem, it's a lot of little things. And when we can work the problems, and the evidence suggests that when you fix the operational issues, we not only improve physician satisfaction and engagement, but performance as well. Accountability and execution, we have to fix what we know doesn't work. It's interesting, when I first took on this role, I went to one of the worst performing units in the hospital and found 4 issues. The caseworker and the social worker, 2 people responsible for getting patients out of the hospital, hated each other and couldn't be on the same floor together. The nurse manager never came out of their office. Physicians weren't rounding. And it was a heavily procedure-dependent floor where 20% of the procedures that were scheduled were canceled on the day they were supposed to be done. So we got a group together, a social worker, care manager, the nurse manager, somebody from the Office of Patient Experience, and a physician champion. And for 2 weeks, all they did was focus on the little problems that everybody knew existed, but nobody talked about. And after 2 months, we had the highest rise in patient experience scores across the organization. And by the way, every issue that they worked in, there were only 4 of them, improved safety and quality of delivery as well. So we don't have to focus on fancy new things. We don't have to bring new processes in. We have to focus on the things that we know are not connected together, and then ask yourself, what are the best practices that I can be executing to bring value to what I'm doing? And then ask yourself, how are you holding people accountable? And are they doing what you need them to do? 6 elements. It's not just about value-based care. It's about transforming how we do what we do better. And it's not new. It's connecting what we've done or what we should have been doing all along and making it more into a cohesive strategy. And it's paying attention to how we deliver care, not improving how we drive patient satisfaction. At the end of the day, our collective responsibility is to reduce suffering. There are things that we cannot do for patients that can ever relieve the pain and suffering of a terrible diagnosis and the treatment that goes along with it. But we can make the care around that better. And there's a lot of processes that we can reduce and improve to decrease this concept of avoidable suffering, where every day we're doing something to make it worse for patients, and we don't need to be doing that. Keeping patients at the center, thinking about our collective goal of helping to reduce suffering, recognizing that it's not only decreasing patient suffering, but it's helping to develop our cultures, improve our people, so that we're reducing caregiver suffering as well, are the critical things that we should be thinking about. And like I started the presentation with the story of my father, we should recognize that the work we do is not just for the people we serve. The work we do is for us, because we are all part of this healthcare ecosystem. And we're not just part of this healthcare ecosystem because we work in healthcare. We're part of it because we are in healthcare, because we're patients, or we will be, and our families are patients. So we do this for the people we serve. We do this for ourselves. We do this for our families. But focusing on the right things, the idea of improving the patient experience to enhance safety, drive quality, so that people are walking away from our environments feeling cared for, is how we should be thinking about this. Thank you very much. It's been an honor to be here today.